Welcome to The Explainer. Today, we're going to tackle two medical conditions that affect millions of women, but are so often shrouded in silence: genitourinary fistula and urethral diverticulum. Let's get right into it.
I want to start with a number that's, well, it's pretty much impossible to ignore. 2 million. That's how many women, just in Asia and sub-Saharan Africa, are estimated to be living right now with unrepaired obstetric fistulas. It's a staggering figure, and it really shines a light on a profound and often hidden global health crisis.
So that brings us to the big question, right? What exactly is this devastating but also highly treatable condition? To really understand the solution, we've got to first understand the problem itself. So, let's start by breaking down what a genitourinary fistula actually is. A good way to think about it is as an unseen internal injury. At its very core, a genitourinary fistula is an abnormal connection. Think of it like a tiny tunnel where one just shouldn't exist. It links the urinary system to the genital tract. And the result of that? A constant, completely uncontrollable leakage of urine. Really, you can think of it like this. A fistula is basically a glitch in the body's own healing program. After some kind of injury, instead of the tissue healing shut and forming a normal scar, things like poor blood flow or an infection can totally disrupt the process. The result isn't a sealed wound, but a chronic, open tunnel. Okay, so what causes that initial injury that leads to this healing glitch? Well, the answers reveal a pretty stark global divide. The causes really are a tale of two different worlds. In developing nations, the huge majority of these are a tragic result of childbirth, specifically prolonged labor where constant pressure from the baby's head cuts off blood flow and damages the tissue. But in developed countries, it's a completely different story. Nearly all cases are iatrogenic, which is just a medical term meaning they're an unintended consequence of pelvic surgery, with hysterectomy being the most common one. Now, while a fistula is an unwanted tunnel between two systems, our second condition, a urethral diverticulum, is a different kind of structural problem. This is an outpouching, basically a small pocket that forms right along the wall of the urethra itself. So how does this little pouch even form? It's usually a four-step process. First, one of the tiny glands that line the urethra gets blocked up. Second, that blockage leads to an infection, and an abscess starts to form. Third, that abscess eventually bursts and drains into the urethra. And finally, what's left behind is a permanent little pocket connected to the urethra, and that's the diverticulum.
All right, so how would someone even know if they have one of these conditions? Let's talk about the key warning signs you'd need to watch for.
For a fistula, especially one that happens after surgery, the classic sign is pretty unmistakable. It's a continuous, unexplained leakage of urine from the vagina. This isn't like stress incontinence that happens when you cough or sneeze. This is a constant dribble that usually shows up about 1 to 3 weeks after an operation. Now, for a urethral diverticulum, the symptoms are often remembered by the 3 Ds. That's post-void dribbling, which means you leak a bit after you think you're finished, dysuria, which is pain during urination, and dyspareunia, or pain during intercourse. That combination of the 3 Ds is a classic telltale sign. Okay, so you have these symptoms. What's next? How do doctors actually confirm what's really going on? Well, it involves a combination of a really careful physical exam and some very specific tests. The diagnostic toolkit is actually pretty impressive. It all starts with the fundamentals, a really meticulous physical exam. From there, doctors can use some clever low-tech methods like the 3 swab test, or they can take a direct look inside with a tiny camera in a procedure called a cystourethropy. And, of course, they can use powerful imaging like CT scans or MRIs to get the full picture. And that 3 swab test is just brilliantly simple. It's a low-tech but super effective way to find a fistula. By putting gauze at different depths in the vagina and then filling the bladder with a blue dye, a doctor can see exactly where the leak is coming from, all based on which piece of gauze gets stained blue. When it comes to urethral diverticula, though, modern technology is really the hero. MRI has become the gold standard, and it's easy to see why. The incredible detail it gives you of soft tissue provides surgeons with a precise roadmap of the diverticulum's size, shape, and complexity. And that's all critical info for planning a successful repair. Now for what is probably the most important part of all this, the path to resolution. And the great news, the really fantastic news, is that both of these conditions are highly treatable.
For fistulas, treatment usually follows one of two main paths. For really small ones that are caught early, a conservative approach might work. Just using a catheter to keep the bladder empty for a few weeks can actually let the body heal itself. But for most, the definitive fix is surgery, where a surgeon meticulously closes that opening in multiple tension-free layers to make sure the repair is strong.
And you want to talk about hopeful? Just look at the results from surgery. For obstetric fistulas, we're talking about an 81% success rate on the very first try. Even if a second surgery is needed, the success rate is still 65%. This is not an unsolvable problem. It's a condition with a clear, tangible solution.
The surgery itself can be done in two main ways. The most common route is the transvaginal approach, which is less invasive. But for more complex or hard-to-reach fistulas, a surgeon might use a transabdominal approach, going through the abdomen and bladder. The choice really just depends on the specific characteristics of the fistula.
And what about a urethral diverticulum? Well, the treatment here is also really tailored to the individual. If the little pouch isn't causing any trouble, doctors might just recommend observation. But for those who are experiencing those 3D symptoms, the gold standard is a diverticulectomy, a procedure to completely remove the pouch and get things back to normal. Let's just put one final number on all that hope. The cure rate for a primary surgical repair of a genitourinary fistula is an incredible 75 to 100%. That's a powerful testament to just how effective modern surgery can be.
And that really brings us full circle. We know these conditions can be devastating, but we also know they can be fixed. The challenge then isn't a medical one, it's logistical. So the question we're left with is this: with such highly effective treatments available, how can we bridge the gap between the millions of women living with these conditions and the care they so desperately need?